This podcast is brought to you by the Mental Health Advocacy Network. MHAN advocates for a consumer, family-driven mental health system of care that provides an array of service choices that are timely, responsive, and effective. Our vision is for every North Dakotan to have access to the right service, whether it be preventative, treatment, or recovery, at the right time, when the service is needed, and at the right place, as near his or her home as possible. To learn more about MHAN, our advocacy efforts, and literature about the North Dakota mental health system, visit our website at www.mhan.org. Again, our website is www.mhan.org.
Hey, everybody, welcome to another episode of the MHAN podcast. We have a wonderful guest today that's going to explain something that I think is a little, to a lay person, is a little bit complicated. And we have a fantastic guest who's going to really make it as simple as possible, how it's distributed and what this kind of means to the state of North Dakota. Would love to welcome Monica Haugen. She is the State Human Services Department Behavioral Health 1915I Program Administrator. Monica, welcome to the MHAN podcast.
Thank you.
Very excited to have you on the show. And I feel like if we kind of kick everything off of, maybe you can kind of describe what your position is, how long you've been in that role, and then maybe kind of start with that 50,000, 30,000 foot view on what 1915I is all about.
Yeah, sure. So my position as the program administrator in the Behavioral Health Division is largely provider engagement. It's working with providers to help them get enrolled, to provide training and technical assistance with them, to do outreach for potential providers all over the state. I do a lot of visits, a lot of cold calling, a lot of reaching out as I'm getting referrals from people. And with that also, just the day-to-day administrative duties, which are, I can't even describe what those look like. It's just a lot of, responses to emails, phone calls, there's so much interest in the program and so many questions, and just there's a lot of administrative work that goes along with that. I've been in my role for 15 months. I started in April of 2021. So I have to say I'm very grateful to those who came before me and did all of the hard work of actually writing the state plan amendment. I entered the picture after the implementation phase had just begun. So I entered as we were kind of trying to navigate what this actually looks like, because as we know, on paper, everything looks much different than it does in the real world. So, when I came on, it was just kind of monitoring how things were going, identifying roadblocks, trying to break down those barriers as we were encountering them. And that's kind of what I continue to do to a large extent as well. Those things are still continuing to pop up as we're seeing higher enrollment, both with providers and individuals. So the 1915I, from that high level view, is really just a way that we can bring some more supportive services to individuals with those behavioral health needs and provide those in the community of the person's choice. The main intent is really to help people avoid having to seek a higher level of care than they might need, those institutional placements, psychiatric placements, nursing home placements, those types of things, and really to, help them avoid having to move somewhere else to get those services they need to be safe and live the life they want to live. So that's what the state plan amendment allows us to do, is provide some additional home and community-based services. We introduced some new services that haven't been provided in North Dakota before. And it also allows us to have those providers who have already been providing some of these services for free to have a billable source for that service provision. So, the reach is really wide with how 1915I benefits our state. Individuals, providers, as well as, we really have a chance to bring in kind of a non-traditional workforce. We're looking for folks, who provide that peer support. We're looking for folks who have that shared lived experience with those folks with behavioral health needs that need the services. So, that's not somebody who would typically fit into what was previously thought of as someone who would be a behavioral health provider. So it's just really exciting all around to kind of to be able to bring that level up in our state of what that behavioral health support looks like.
Monica, there's a lot of services that the 1915I can provide somebody that qualifies for the 1915I, but at the same time, a lot of people don't even know what services those are or even how they can help. Just when social workers or administrators talk about certain programs, people are like, well, I have no idea what that is. So given the fact that the 1959 is really complicated and there's a lot of services that can be provided, could you give kind of a description of some of those services or all of those services and how they might be beneficial to people?
Yeah, I sure can. That's a great question, Matthew. I think it's really important for us to be able to break those services down. And rather than telling someone we can give you housing support, tell them what that means. Folks who qualify for 1959 services, they want to know how this is going to help them. They don't need to know the name of the services, and it's kind of just, a high level name. So everybody starts when they're approved with care coordination. That is a really critical role because that is the person who helps them assess what other services they need, helps them talk about what their goals are and what services can help them reach those goals. So the care coordinator is the only person who can help the individual connect with those other 1959 service providers and get those services. So it's everybody's first stop. Everybody gets care coordination. And then we have services like peer support and family peer support. Those are two really important types of service that are really growing in popularity. I think nationwide. In North Dakota, I know we're really trying to build our peer support networks. So that's, just someone with shared lived experience that can kind of walk alongside of somebody and help them navigate those things that are challenging. It's somebody who's met similar challenges that kind of come through the other side and is able to be successful and safe and happy in the community and wants to use that experience to assist other people with those same challenges. So, really, really critical supports. We also can offer non-medical transportation, which that's exactly what that is. It's transportation of things that aren't medical appointments, but also not to regularly reoccurring things like work and school. It's those additional things, help getting to those resources in the community, those activities in the community. They're going to help them integrate into the community and feel part of the community and, utilize those resources that are available. It might be, community classes they might take, support groups, social groups, maybe it's rides to the library, maybe it's, rides to the grocery store if they have a goal related to meal planning and better nutrition, as long as it relates to a goal that the individual has that's related to an assessed need. That's how Medicaid says, yes, we can pay for the service. And that's the same for all of the services.
And Monica, I was going to ask, you might have gone over this a little bit, but in terms of the differences between how services might be beneficial to an individual, how does that look for a family that's trying to assist a child or a family that's raising a child with a behavioral health condition, but at the same time, they also need support needs?
Right. Yeah. And, most of the services that we provide that are deemed kind of children and youth services really are geared more toward that family unit. And the definition of that family unit is very broad. That could be any sort of, guardianship, grandparents, foster care, adoptive parents, biological family, whatever it is. But, the idea is to provide that support to the family unit. So that parenting support, that guidance, those resources, building self-advocacy skills. One thing about family peer support, which I think is kind of unique, is that this can be provided to a family if there is disruption in the family. So if there's a child in foster care, this support can still provide that family with the support they need to bridge those gaps, to help them with those reunification efforts. So it's a really valuable resource for the families. It's, anything from parenting support, conflict resolution in the home, home management, anything that's going to help them in that kind of caregiving and provider role. Yeah. So, and that's kind of the same with my next service I was going to talk about is training and support for unpaid caregivers, which is actually a brand new service to North Dakota. In fact, we have yet to have anyone receive it. We have a couple providers just ready to roll on to provide it. So I'm really excited to see what that looks like. It's a 2-tier support. So there's a financial piece and there's an actual physical support piece. So the financial piece is $500 annually that parent or caregiver can use to access educational resources, go to conferences, take classes, anything that's going to help them in that caregiving role. And then on top of that, they also receive that hands-on parenting support. So it's really, it's really unique. And like I said, I'm just really excited to see how that benefits our families and the children that we're going to serve. Respite care is another service, that's pretty plain and simple. It's just that short-term relief for the caregiver so that they can take care of things that they need to take care of, or just get that relief that they need from that caregiving role, which can be pretty intense and people can really kind of get burned out in that role. So it's important to have. And then we have supported education, which is really a really neat service because it's not only for children, it's actually for any age 5 and up. So this could look so many different ways depending on what the person needs. This could be another person in a classroom providing support for a child with behavioral health needs. This could be someone working in the evenings, on weekends, over the summer with a child to maintain or to build on those soft skills, those natural supports, social skills, those types of things. This could be for a transitioning age youth who is going to be either transitioning to, being on their own as an adult or transitioning to higher education, community college, whatever it is. This could also be for someone who is 55 years old and decides that they want to become a welder and, helping them achieve that educational piece that they need to achieve in order to meet their goal. So I love the supported education service too. It's just, there's so much potential with that. And then we also have pre-vocational support and supported employment, 2 separate services. So the pre-vocational is all those activities prior to the person actually being employed. It could be job shadowing, volunteering, classroom learning, out in the community learning, all of those things that are going to set them up to be able to be successful with employment. And then that supported employment piece then would kind of be that natural handoff. When they are ready to be employed, then it's kind of that initial really kind of intense support, tapering off maybe to just that follow-along support that someone might need. In the beginning, it's how are you going to be a good coworker? How are you going to navigate things? If you disagree with your managers or you disagree with someone at work or a customer, kind of helping people navigate through those difficulties, really just helping somebody get a job and develop the skills they need to keep the job in a competitive employment situation. And then housing support is another one that's kind of it's like a 2-tier support as well. So what that could look like pre-tenancy is somebody literally out looking for apartments with someone, helping them understand the leases, helping them access those resources they might need for deposits, for utility deposits, all of those things out in the community that exist, accessing those support things that are available. And then it can also be after someone does secure that housing, then it becomes that support to keep them housed, right? So it's, how do you make sure you're following the lease? I attended a training just a little while ago that was really great that talked about using the lease as an actual support tool for the person and kind of developing some objectives and some work around that lease to make sure that they're maintaining their place like they need to. They're not going to be at risk for eviction. Just all of those things that could jeopardize their housing and kind of helping people work through those and building those skills. Benefits planning is another service, and that's really just that budgeting piece. That's okay. If I start working, how's that going to affect my Social Security benefits? What do I need to do to report my income to the county for, to maintain my benefits? All of those questions surrounding your, benefits and work and how all those things work together. And then the last service is community transition service. And this is actually the one 1959 service that is geared toward people who are not yet eligible, because they meet all of the eligibility criteria, except they are living in a setting that's an institutional setting. So this is funding to help them transition and to meet that last eligibility requirement, with the idea that once that transition happens, then they would be eligible fully for the array of services and receive those to be supported to be able to maintain their place, their new place in the community. So those funds could be used for furniture, deposits for utilities, moving expenses, pots and pans, just anything they need to make their house a home is what those funds are for.
What I like most about this, and thanks so much for describing that, because I think that is it's a fantastic sort of overview on everything tethered to this program. It's almost like here's a list of things that we don't provide, and that's a shorter list than what you do. And as a supplemental list to questions that maybe parents have or individuals have, going, boy, I'd love to do this. It's this wonderful catch-all that allows you to do the things that you want to do to become independent and still, provide all these services. And I think that leads to another question, which is, okay, I'm a parent, I'm a family, I'm an individual. This sounds really fantastic. How do I qualify? And then after I qualify, how can we get evaluated for qualification? Right. So those are the two things that I think, this sounds great. How do I get into this?
Yeah. And that's a great question. We have a set of eligibility criteria that's established, and I can go down the list and list those off for you. It's any age. I don't know why that's one of the criteria, because it's literally 0 and up. But the individual does need to be enrolled in Medicaid or Medicaid expansion, because these services are billable to Medicaid. So both the provider and the individual need to be enrolled to provide and to receive the services. And that's how that billing piece works. The individual does have to have a qualifying behavioral health diagnosis. Now, our list is very, very long. It includes any substance use disorder. It includes most mental health diagnoses, and it includes a handful of brain injury diagnoses. And admittedly, we need to review those brain injury diagnoses and do a better job of incorporating more. But for now, I think it's 7 or 8 different brain injuries that qualify. So in the beginning, we encountered a lot of people who were helping folks apply, and they were saying, I can't believe this person has this diagnosis. I can't believe they don't qualify. We took that and we really worked hard to build a new list, a new qualifying diagnosis list, where we incorporated anything we possibly could to get people qualified within reason and within the confines of what we could do with the amendment. And there were a lot of folks that helped out with that. I'm happy to say that that new list was approved January 1 with our new amendment that we had approved, and we haven't had anyone denied enrollment based on not having a qualifying diagnosis since then, where we did before. So that's really been fantastic. So that eligibility piece is that qualifying diagnosis. The individual also has to have a household income at or below 150% of the federal poverty level guideline. And there are charts available. If anybody has questions on that, they can feel free to reach out, and I can help them determine, where to find that information. And the individual has to have a HUDOS score of 25 or higher. And probably the general layperson has no idea what a HUDOS is. In the behavioral health community, it's been a topic of conversation for the last couple of years. But essentially what it is an assessment that is used to determine someone's level of functional impairment. So what it does is it divides someone's life into 6 different domains that could be how they function in the community, self-care, how they function at home, at work, at school, getting along with others. And it's an assessment that's a 32 question assessment that helps determine a score in each of those areas. And then there's an average that's taken. And so essentially the higher the number, the higher the score, the higher the level of functional impairment a person has. Now, when we started right out of the chute with 1959 in February of last year, that HUDA score requirement was 50. My understanding is that that's a pretty significant level of functional impairment. Again, we really rely on our stakeholders for feedback, and we got it. And there was just a lot of people who really felt strongly that we needed to lower that score to bring more people into services. And we were successful in negotiating that with CMS down to 25. So that has allowed a lot more people to become eligible. I don't have the data on that yet, but I was asked to take a look at that data, and I plan to release that. I do a monthly report that's on our website about enrollment, and I do plan to go back and backfill that data and take a look and see how many more people have been approved now because of that lowering score. I think it's going to be interesting to look at. But yeah, so that's that 25 HUDA score is one of those eligibility requirements. And the last one is that they live in that home and community-based settings, which essentially means that they don't live in an institutional setting as per Medicaid guidelines, right? Which is a hospital, a nursing home, a DD, IDD group home that's at that ICF level, that intermediate care facility level. Basically, again, the list of what qualifies is much larger than what doesn't. So any, apartment, home with family, with friends, homeless, shelters, recovery homes, living in your car, living, wherever you live, as long as you're not in that institutional setting, you would qualify based on that home and community-based settings rule. So yeah, so those are the qualifications. Somebody who meets those qualifications can go on our website and fill out an application. It's a fairly simple application. It's many pages, but 6 of them are diagnoses that qualify. And then there's a couple pages of instructions too. So you're going to pull up a PDF that's going to be 13 pages. Don't worry, it's not 13 pages of information. It's just 3 small sections. So we capture that demographic information, make sure that they do meet the home and community-based settings rule based on their, where they're living and those kind of things. And then we have a section where the person who does the HUDAS assessment fills in that information and, and their information stating that they were qualified to do so. We have a section where there's the diagnosis verification. And again, in the beginning, I keep talking about these things that we've identified and kind of worked to fix and make things smoother for the individuals. This was another thing. We originally required a diagnosing physician to sign off to verify that those diagnoses were accurate for the person. And that they had those diagnoses. Now, realizing that was a barrier for people, it's hard to get in with physicians. It costs money to get in with physicians. That was really something that was preventing people from enrollment. So we took a look at that, and we still needed to verify those diagnoses, but there had to be a better way. So we decided that we could accept a printout from someone's electronic health record containing that information. Didn't need to have an actual signature from the physician. That's in their record. It's official. So we were able to accept that. So if they have maybe a Sanford My Chart or, some other sort of electronic chart at the hospital or the doctor they doctor with, or the human service centers, a lot of folks take advantage of the services there as well. And we can accept a list of diagnoses from the human service center as well. So once that application is filled out, it goes to the human service zones, which is the old county offices. And there's an eligibility worker there who processes the application. And the individual gets a letter saying either, yeah, you've been approved, go forth and choose a care coordinator, or you've been denied because of this reason. And I just have to put in a plug for my navigator. We were able to hire a navigator in December because we realized that people were making those connections independently. And those people that were getting denied for a reason that could be fixed so they could go back in and reapply, that wasn't happening. So I hired our navigator to mitigate that. So she is helping people whose applications are incomplete, make sure that they're done. She's helping people who have been approved, make sure they're getting connected to that care coordinator. And she's helping those folks that are denied who could be eligible with a small change get there. So that's been a really important thing that we've added to the mix that's really helped with folks becoming eligible and connected to those service providers.
Thank you, Monica.
Long answer. Yeah.
No, it was great. Because that is a perfect segue into the next topic, which is talking about the implementation of this massive program. There's a lot of people in North Dakota that do not know that, while the legislative session meets once every 2 years, there's a lot of work that's been going on over the last several years in terms of human services and behavioral health services in general. That is overwhelming in many respects. So we wanted this podcast to be educational about for our viewers, to not only let them know what services are available, but also give them an in-depth discussion about how this work is being done and what you have learned along the way. So, one struggle was the concept of building the 1915I, and I and other advocates were involved in that discussion as well. But then the other big hurdle is actually implementing the changes that have been authorized. So, and as well as discussing the strengths and weaknesses of our approach in trying to make this stuff work. So, first, you've discussed a lot of things that you have done to correct course every once in a while, but were there any other successes that North Dakota had in devising and implementing the 1915I that are not getting a whole lot of attention?
Yeah, there are definitely. And you're right, Matthew. Typically, you hear about all the bad things that are happening, the problems, the complaints, the barriers that people are experiencing. But we've seen some really amazing things that we're incredibly proud of through this implementation phase. One of them being the willingness of a few of our providers who just in the beginning were ready just to jump in, and they really navigated this implementation right alongside us. We were partners in this, and we owe such a debt of gratitude to them for partnering with us so early in the process. We have been through a lot. We've experienced a lot of issues and a lot of things along the way that we've had to fix, and just incredible partnerships with people and with agencies. And alongside of that too, we've seen kind of an unintended side effect is that we've seen providers of all different types starting to collaborate across, churches collaborating with kind of that more typical service delivery model, DD and human service provider. We've got shelters, we've got community action agencies, like you name it. There's no typical 1959 provider. So it's been really cool to see that collaboration between providers and that support that they've been able to offer each other. And, just those relationships that are being built around the state, which is really critical to the success of 1959. Because of the necessity of, that care coordinator making those referrals to those other agencies for those other services. So that's been really amazing. The other thing that I just really have to say I've so enjoyed seeing is that we've received so much feedback. We have some really invested, really passionate stakeholders, and I cannot give them enough credit for being vocal about you're not being afraid to stand up and say, this isn't right, this doesn't work. What are we going to do about this? Because we took every one of those suggestions, every one of those issues that was brought to us and staffed those and figured out a way that we could make things work. And, I have to say we're far from perfect at this point. I don't know if we'll ever get there, but the services that we're able to deliver to the citizens now based on that feedback are so much richer, and just it's improved at every level. So I think that's such a win for North Dakotans to be able to say, this is our, this is the services that we need. We need to be able to have a voice in this and, really be able to make a change and change things for the better has been really awesome. So.
Well, you talk about a lot of the provider and the partnerships that you've got and the feedback that you constantly get. Do we have enough providers? I mean, you're looking at the amount, right? So you're listing off all the things and you're listing off all the opportunities, and the implementation process is just this massive, giant undertaking. How many providers do we have? And then when you're looking at kind of some of these numbers, are they businesses? Are they nonprofits? Are they groups? And like, this is like the big question of like, how do you do any of this, even with the amazing partners that you have?
Yeah, it's such an amazingly huge undertaking. I'm in awe of how big it is and how much progress we've been able to make. Right now, fully enrolled to provide services, ready to go, we have 30 providers. That's group providers, that's agency providers. And that means that not only do they have their group enrollment done, they've also enrolled their individuals to be affiliated with them who are actually ready to be boots on the ground providers. So we're at kind of varying stages of readiness yet at this point in the rollout process and adding them to our enrolled provider list so they're available for referrals. But yeah, we have, and that list is growing. We have, on top of that 30 group providers that we have, within those, we have 100 individual providers who are enrolled underneath those group affiliations. But that doesn't mean that one provider is providing only one service. Most of those individual providers are providing a multitude of services. So they're able to provide, the housing support and maybe the supported employment and maybe the benefits planning to someone. So when you look at those numbers, they can be a little bit deceiving because 100 providers for a state geographically as large as North Dakota doesn't seem like very much. But, and it's not enough. And I don't know that we'll ever have enough. I don't even know what enough looks like. But in my mind, kind of when we'll reach that point will be when individuals have true choice in their providers. When I can provide a list to someone of 3 different housing support providers they can choose in their area, right? Rather than just, you have choice, but we have one. So here's your choice. And I'm glad that we have that one choice right now. But really, I'd like to get to the point where we have multiple choices for everybody because individual choice is so important. And, people may have felt kind of burned by a certain agency and not want to receive services from them. And if that's their only choice, then they're hesitant to give that a try. So it's really important on so many levels to have that. My work with trying to engage new providers, I don't think will ever be done. We're really highly concentrated, I'd have to say, in the Fargo area right now. That's where we're in the best shape for providers and individual choice. But we, and some of these areas are just really, really hard because, we hear about workforce. That's probably the biggest hesitation, aside from the hesitation to enter into providing Medicaid services. Because for a provider who's never provided Medicaid services before, wow, is that scary? It's just a lot. And so, we've been doing what we can as far as, training and trying to kind of offer some additional training opportunities and, help those providers transition into that Medicaid billing. And just trying to be really creative about what we can do to provide that training and technical assistance to providers. The focus, it's interesting because we have, people aren't going to enroll unless we have the providers. But then the providers are saying, until there's people, I don't want to enroll. Like, what if I enroll and then there's nobody? So it's this really delicate balance that we're striking every single day. And so we're kind of inching up on both sides. And I think that's going to kind of continue to be that trajectory that we follow. I don't think we're going to see a huge spike in providers with no individuals to receive the services or vice versa, honestly.
Monica, you brought up an interesting point that I think most of us do not understand what you mean by becoming a Medicaid provider is a huge challenge. What kind of challenges are you referring to? Why is it a lot for?
Yeah, well, along with Medicaid, the enrollment process, I mean, it's involved. It's fairly involved. A lot of steps. It has to be very precisely done. And not only that group enrollment, but that individual enrollment. And, if there's an error on the application, it has to be fixed and resent and kind of start the process over. And then there comes the questions about what do our policies and procedures need to look like? How do we incorporate Medicaid practices into our current business model if we've never done that before? And then the billing piece, that claim submission piece, because it's fee for service. So you're not getting money, say, from a state contract to provide, overall services as an agency. You're now saying, I've provided this, here's the proof, please pay me. So it's there's that period of time between that service provision and that reimbursement for Medicaid that's kind of difficult sometimes for those providers to take that hit. They're still got to pay their employees, right, during that time. So there's a lot of things to consider, when considering becoming a Medicaid biller. There's a lot of assistance and technical help out there. But it's a big decision, and it's not one to be taken lightly. And it's a lot of work on the back end getting there.
Well, you talk about that as a chicken or egg kind of thing, right? So providers are people and people are providers, right? So, I mean, how are we, sort of as the entire system itself, how are we trying to get people enrolled? Like how do we get providers enrolled? Is the confusion there where, okay, we need providers to enroll, we need people. What's the communication? What's the process by which we're working on both ends so that we're communicating as one to go, hey, if you need it, it's there. And here are the folks who are helping.
And I'm the person to answer that because both of those things are on my plate, right? So
I knew it was the right question to ask.
So in the beginning, most of our enrollment came from folks who were receiving services at the human service centers. Maybe they had mental illness case management, maybe they had behavior modification services, something like that. And their provider there felt they met the eligibility requirements, helped them with that application, and got that submitted for them, right? So beyond, not everybody receives services from the Human Service Center who needs 1959 or who'd benefit from those services. So then it becomes, my net needs to become much larger. I need to start talking to private providers, different referral sources, getting the word out about 1959 and what it does and how it could benefit the folks that they serve. And, at some point, most of the folks who are eligible for services at the Human Service Center, are going to have applied and are going to be, approved for those services if they're going to be approved. So then in order to keep growing, we're going to need to bring these services to people, make them accessible for those folks who aren't involved with the Human Service Center. And on the other hand, too, with the providers, I have a lot of conversations with providers about, okay, we have, 15, 20 individuals here in this community waiting for a provider. I mean, I hate to say we have a wait list, but we have a wait list because of, providers not being able to do that outreach into those far-reaching areas. Maybe they're located in Williston, but somebody lives in Watford City. There's no reimbursement for paying that staff to drive to Watford City. There's no reimbursement for that mileage, getting them to that staff, right? So we're doing a lot of things like we're developing a rate differential for providers to allow them to recuperate some of those costs, depending on the radius that the person is from their service location. And we're just trying to get creative about how we can make it work and how we can get those services, to expand throughout the state rather than concentrated in those metro areas. Yeah, it's been a really unique challenge, but it's really exciting. Every time we get a new provider that commits, it's just such a win, especially if it's in an area that's really underserved. It's just such a great thing.
So how can providers join 1959 service delivery? And about how long of a process does it usually take for people to become those enrolled Medicaid 1959 providers?
So they would, anybody who's interested, first of all, certainly reach out to me and I can provide some guidance. The guidance I will provide, though, is to go to our website, and we have a section right on the front page. It's behaviorhealth.md.gov/1959. There's a box that says how to become a provider and provide services. And if you click into there, there's the instructions on how to enroll for Medicaid, the different steps that need to be taken. Now, I've seen few providers who have been able to just whiz through that on their own without any support or guidance or, somebody to answer questions. So that's what I'm here for, is to provide that assistance for our providers as they work through that process. I also have contracted with a vendor who will be providing some really intensive Medicaid training to providers, which I'm really excited about. Currently, we have 30 providers signed up to 30 group providers signed up to take on that training, and with the end result hopefully being that they will be enrolled and ready to provide services. It's a 6-week course they'll be taking. So this is really exciting stuff. And not only that, but if they can't participate in that training, we will own that training material. So that will be available, that we can share that with providers outside of that training, those specific training parameters. So that's really exciting. But yeah, it's just a matter of doing that application, providing them the information that they need. It's a step-by-step process. And I've seen where providers gone through in maybe 3-4 weeks, and I've seen it take months if there's a lapse in communication. So it's really a matter of staying on top of, making sure you're responding to those emails from Medicaid. If there's something wrong with the application, they're going to reach out. And if that email gets buried, that's problematic. So, and I've found that I'm able to, I have a few contacts with provider enrollment that I'm able to reach out to if there's, if I've seen somebody's status stay in one area for too long and not moving up the chain of being ready to go. So yeah, we're just trying to kind of do whatever we can to help people move those applications through, but it can be a slow process. Nobody's going to sign up and be ready to provide services in 2 weeks. It's just not realistic.
To back up a bit, because you had mentioned that there's kind of a more enthusiasm in some communities than in others, or more success in certain communities than others, primarily in Fargo, and maybe other metro areas compared to smaller cities or towns. The question that I have too is that a lot of times in human service delivery, there's kind of a differentiation between different populations that are receiving services. So not just where you live, but how old you are. So are we, in terms of providers being able to provide services to different people of different ages and different stages of their life, is there currently kind of an imbalance or more services for one age demographic than another? Are we having more providers that are able to provide services for adults in comparison with children and families? Are there any emerging trends that you see?
Yeah, there's definitely what I would call an imbalance right now. Adults are going to have a lot easier time getting served. And we have a lot of work to do, and we've identified that work that we need to do with engaging with those providers who do specialize in providing children's and family services versus individual adult services. We have a lot of great ideas. I've had some great conversations with school districts in the last week or so in implementing 1959 services in the schools, which is a fantastic opportunity. I've had some conversations with some healthcare systems and some clinics, in those more rural areas. That's going to be a key thing too, is getting those services provided by staff that are already there. Workforce is a problem. So let's identify those areas where they do have pretty decent staffing levels and see if we can get in there and see if they can provide some services. We're really just trying to be very creative with our outreach, with our ideas, with talking through with providers what this could look like, and helping them kind of plan and see, like, revenue wise, what does this look like for your agency if you were to implement 1959, and really, we don't want to convince any provider that it's a good idea if it's not going to be a good fit for them. But there are so many, it's literally unlimited as far as what different types of organizations could be providers. There are certain qualifications they have to meet, but the sky's the limit, really, as far as, getting creative around the state. So that the work for children and families, Matthew, is something that we're definitely going to be focusing on very significantly in the next, I'd say, 6 months, and getting some different things going. Yeah, so I'm really excited about that.
Well, Monica, thanks so much for making this understandable. And again, I realize that as a listener and somebody who is again not into it every single day, it's a little overwhelming. But the fact of the matter is, if you have a question of is there something that I probably qualify for, the answer is seemingly yes. It's seemingly very intuitive and a little more simpler than it sounds to apply and qualify. And then it's really just a providing catch-all for this wonderful series of programs that allow you to be awesome as a human being, regardless what that looks like. And so I wonder, it's kind of like the closing question. It is as you're looking into your crystal ball, as someone who's a specialist who's trying to administrate all of these programs that rolls out. We're at a year and a half of implementation to the 1959. It's all over North Dakota. You've had conversations with leadership across the way. What's the future look like in the next year or so on some things and goals that we can look for or expect or anticipate?
Yeah, I think some of the big ones is we definitely want to grow that children's and family services provider option all throughout the state, and just tapping any of those resources that we can tap along the way for that. We want to, kind of just continue to identify those barriers like that providers are seeing with actually doing that outreach, and seeing what else we can do as far as, helping them stay staffed and providing maybe some incentives for their staff and those kinds of different things. And then another big thing that I think is really important, but maybe kind of boring to some people, is we really are at a point now where we can start looking at the data. We can start capturing things systematically that are going to be important to look at. And that's, how long are people waiting to get connected to services once they've been approved? And looking at what we can do to shorten those times. How many people are actually getting services? How many people are getting what they need versus just getting the bare minimum? There's so much data that we can capture that will tell us a fuller picture of what the implementation looks like throughout the state, and where we need to focus our efforts, and what kind of oversight we need to bring in to ensure that people are getting served. So I'm really excited about that piece, and just being able to clearly identify what direction to go. We don't know what those directions are right now. I kind of have an inkling that it's going to be, broader range of services provided to people. But there might be some surprises along the way too, as we start to look at that data too. So I'm definitely open to whatever the data tells us is important.
Monica, I know that there's roughly like 10,000, 12,000 or so individuals that may qualify for these types of services. So in terms of anybody in the public that is looking for information to go to about mental health services, behavioral health services in general, as well as the 1915I, where should the public go to get more information?
I would really direct anyone just to that behavioralhealth.nd.gov website. We offer a huge array of services to citizens of North Dakota, whether that be substance use disorders, mental health concerns, parenting needs, just the full spectrum of services that individuals need. So I would really, that's a great start. There's a link to the 1915I page on there, but there's also links to some of the other programs that we administer, such as Community Connect and Free Through Recovery. And really, if a person has a need, I really feel like if that's where they land is with those behavioral health services, through our division, they're gonna find a way to get those needs met. And also just, if you're hitting roadblocks, reach out, keep reaching out, follow up, just be persistent and be a good advocate for yourself so you can get those needs met, because the services are there.
Monica, thanks so much again for being a guest here on the MHAN podcast. We're going to mention and put all those links in the show notes. So if you are finished listening to this podcast, get in there, click, send it to folks that send it to folks within your communities that they know about these programs. They know about where to find, sort of answers to the questions that you're trying to figure out. And appreciate you clarifying a lot of things on what again I see as a very complicated, very massive program, done in a way that I think everybody who's listening today understands. And I so appreciate for your time and your perspective. And from Matthew and all of us at the MHAN podcast, thanks so much for being a guest today.
Thank you so much. Have a great day.
This podcast is brought to you by the Mental Health Advocacy Network. MHAN advocates for a consumer, family-driven mental health system of care that provides an array of service choices that are timely, responsive, and effective. Our vision is for every North Dakotan to have access to the right service, whether it be preventative, treatment, or recovery, at the right time, when the service is needed, and at the right place, as near his or her home as possible. To learn more about MHAN, our advocacy efforts, and literature about the North Dakota mental health system, visit our website at www.mhan.org. Again, our website is www.mhan.org.